Okay,
And it's got
just
sound
pause,
too,
just
if we
pause
want.
it for a second. Okay, so if I tap on it now, it will play.
Yeah, just
Okay.
sound as well on mute. So
Okay, cool. You know, look at data on file, look at what are the survival rates of these implants. I mean, Straumann's got long-term survival rate trials of implants that have been in the mouth 10 to 15 years with high 90 percentile survival rates. Because you're looking for a surgical solution that will last as long as what the data shows you it possibly can last. So, yeah. I'll play this for you guys. Sorry, there's unfortunately not sound on this. But this is just a brief video introduction for you to the new Straumann iXL product portfolio. Sorry, are you going to try and connect sound? Yeah, it's at its loudest. So we call it iXL because we are giving you the solution as clinician to excel through surgical treatment and restorative treatment protocols based on a one implant connection size. So going forward, we'll talk about C-line or X-line. C-line, they say, stands for confidence. That will be the ideal implant for, I'd say, 85 to 90% of cases that you treat on a daily basis, and X-line is your immediacy concept implant. So for large 6-7 exocytes, full arch rehabilitation, posterior maxilla where you've got D4 quality bone and very low bone density cases, that is where X-line comes into its own. Nick, how do I pause? Oh, there we go. So, yeah, that's not our video. So that just gives you an idea. I'm just going to pause here. It gives you a rough idea of the internal connection and what it looks like from the top. So we have got what we call a friction fit implant connection. So the benefit of a friction fit connection is that your stress under constant occlusal load doesn't just live on the screw that engages the abutment into the actual implant. The actual abutment and implant have a friction fit together before the screw engages into the screw channel. So therefore, over time, if you think about that connection, if you think about something like a conventional internal hex design, an internal hex design has normally around a 3-degree micro movement point on each hex, due to the fact that if you have two hexes, if they're not 100% accurately machined and milled, you will never get that hex to engage. So that's why they design a hex with a marginal movement within the actual hex engagement portion. That sounds great to fit it down, but over time, when that hex is in the mouth and a patient's chewing on it the whole time, if there's constant micro movement, that means that your internal abutment thread is wearing. A lot of times, if you've placed the hex design implant over 5, 6, 7 years of time, when you take it out, the hex will start wearing. You'll actually notice that the internal hex part has started wearing out. You might get screw loosening because of it, because there's constant micro movement. If there's micro movement on the abutment into the implant, you could have further cortical stress on or stress coronally on the implant, causing stress on the cortical plate coronally, which could lead to potential risk of bone remodeling and bone loss over time as well. So that is a very unique connection. That connection, has any of you who restore implants have issued with abutment not fully seating and crown or screw coming loose? I think most people that have ever restored an implant has probably had that encounter once, and then when you go back to your original PAs, you would have found that your impression coping wasn't fully seated, or your impression coping or scan body wasn't fully seated when you actually tighten it down. Our internal connection torque fit, if you don't engage the abutment fully with the actual internal interface on the implant, you can't tighten the screw down. So you can't use the screw to drag it into the connection. The two pieces have to connect before the screw will actually connect at the bottom of the screw channel. So it's a very, very unique design, and because of the unique nature of the design, we can also make it a shallower connection design rather than a deeper connection. The benefit of a shallower connection for you is the connection of these two pieces externally and then internally becomes substantially easier. If any of the stuff that I say to you guys doesn't make sense or sounds like absolute garbage, please stop me and tell me. But yeah, that's the principle and the methodology around the new implant connection and why we're moving away from CrossFit into torque fit. That video is actually nicer with sound. I never thought I'd say that because the first time I heard it, I nearly lost an ear to it. So again, just our older generation implants and then how they compare with the newer generation designs within X-Line. So you'll see there's also changes in sizing. The old surgical portfolio had very limited sizes available, 3.3, 4.1, 4.8, and that was it. And then on BLT, we had a 2.9. Going forward within X and then within C-Line, you'll see that we have sizes from 2.9 all the way up to 6.5. We can also reduce surgical portfolio. If you look at, sorry, why is there no cursor on here? Sorry, I'll just move over here. So this is just for reference. This is BLX, that is TLX, that's BLC, and that's TLC. So obviously bone level, tissue level equivalents of the different ones. If you look at the BLC line, I'm sorry, it's actually written right above it. If you look at the BLC part, you'll see that the amount of implant sizes have increased, but there's, for example, a big gap between a 3.75 to a 4.5. The reason why it's designed like that is to be surgically less invasive, and it's because of the fact that with our 3.75, and that's why that one is specifically highlighted, so we've proven that the 3.75 implant has got the same load-bearing capabilities as a 4.1 BLT implant. So you can place something that's slightly narrower without having to worry about the fact that it becomes a weaker implant that you're placing for your patient. So looking left to right, bone level, tissue level, and you'll see the difference in the thread and the design of the implant. You'll feel that they also torque and drive very differently in bone. There you can see how the implant base has changed from BLT on the left to BLC and then the TLC that we have far right. We have the TLC in what we call a regular tissue or wide tissue. That's the flaring neck in the S profile, and then we also have it within a straight neck or a narrow tissue as we call it. I think you guys in the front row, if I'm not mistaken, when I looked at your implants, I think you guys all have the narrow tissue level equivalent, so that's the straight neck design rather than the flaring profile that you see up there. So again, just a comparison on sizes. If you have a look at this, so Jackie, this was what I was earlier referring to as the actual connection point and where the base sits. So if you look far left on the 3.3, you'll see all of our implants all the way through to 6.5 have a 22.5 degree machine bevel at the top of the implant. So depending on whether you're doing a single or whether you're doing a bridge case, your bridge will connect and sit on that outer bevel, so giving you between your two implants up to a 45 degree divergence angle correction based on the bevel connection point. So they don't just sit, because a lot of people are trying to get them to sit on the internal connection of the implant, so you have some level of fit internally, but there's still some risk of microgap formation. They now sit on the bevel with an internal connection on our new bridge abutments that are coming out. And then for anything internally engaging or single implant, they will obviously directly connect internally. And where they connect on that internal basis is, as I mentioned earlier, between a regular base and a wide base abutment, what the profile and flare within the soft tissue will give you. So to not have that lollipop effect. So that is how it's counted. It just gives you an idea of all the different implant types. So all of these implants are still available. That's the complex. That's the bad part of Straumann. It's probably one of the most complex product portfolios out in the market just because we have so many different solutions available. So we can't discontinue any of the old solutions because there is hundreds of thousands, if not millions of some of them placed within the global market that we still need componentry for. And we still have guys that swear by the old generation, for example, up there, the old TL, there's guys who swear by them and they still want them. So we have to keep manufacturing them. But for you guys, how we've set it up is we've essentially selected predominantly BLC and TLC as your two solutions. I don't think any of you would really be encountering cases where you need an extremely aggressive BLX, TLX implant design. It is a very niche implant that works really well in some people's hands, and then for other people it can be quite challenging to manage, whereas BLC, TLC will give you the surgical flexibility and restore the flexibility to manage any of the cases you treat in clinic daily. So that is how we've tried to streamline it. If you want something out of that scope, of course we can have it ordered for you, but as part of your consignment that will be living at Prosthetic Process, it will be based around C-line implants. If any of you need anything different, please indicate that to Nick and we can have it added to your consignment, because we'd also just have to look at surgical componentry to ensure that you have the necessary surgical components for those implants. And then I think that is pretty much that. I mean, here's just a couple of examples of different treatments that can be performed with a C-line implant, but it's literally anything you can imagine can be treated with a C-line. It's a compressive implant design, so even in posterior, like D4 posterior maxillary bone, you'll get really good compression of the bone and good stability rates. I think that is, I don't think you guys want to go into implant specifications and technicalities, right? If you guys want to, we can go on a real deep dive as to how technical we want to be tonight, but it is a Saturday night, so I'm just being mindful of that. Is there any questions around the implants? Because otherwise I think we can maybe jump into the hands-on part of the night. Questions? Anyone? No one? Okay. So yeah, I think that is it from a presentation point of view. What we've done, so each of you will have on your desks, there's a couple of different bits and pieces regarding the flip charts. Just to tell you what they are, the flip charts are basically around BLC, TLC, and then BLX, TLX implant system. On one hand, you'll have all the surgical componentry and their product code. So we use a numeric product code to order our stock by. On the other end, you'll have all of your product codes for your restorative solutions that you have that needs to be communicated to the laboratory. So that's why we've handed these out for you guys who are going to be placing and restoring implants. Therefore, you have a quick reference chart of your implant system surgically and restoratively. It will just simplify it, especially in the transitional stage. All you need to do is you give them that 6, 7, 8-digit code of what stock you want. Regarding the stock ordering, I think maybe important just for me to mention before we go into the hands-on part of the night. Again, to streamline things for you guys and try and keep it as simplistic as possible, what Jackie and myself have discussed is to have an implant consignment living in prosthetic process. They will have access to the eShop, so Nick will train them on eShop integration. Any product that you need from them can be ordered directly from Cynthia and the team at Prosthetic Process. She will ship that out to you guys so that you have the product in clinic. The moment that has happened, she will scan the barcode for the product that's gone to you. It will be registered to your account. We will replenish the stock from our end. The only thing that we have to manage, and Jackie and myself just spoke about this before we started, is your implant surgical kits and where these live. So we just need to have a chat around preferred locations, guys who say, hey, I want to start placing Straumann straight away. If any of you want to put your hand up as to who wants to start placing with Straumann straight away, we can have a surgical kit living there for you guys, but we just need to manage those. What we might have is some of the bigger locations doing more work might have the primary surgical kit living with them, and then the guys, when the other smaller groups or clinics within the group, when you guys place, might just need to request a surgical kit from one of the bigger clinics. PROS components, Nick can have you guys set up on PROS components to make sure that all sites that are restoring Straumann implants have a prosthetic kit available. They will essentially look like the little white box that's on your tables, except the torque wrench will be a different color. I think they'll be silver instead of black right here. So they will have a straight implant driver as well as an angled implant driver, so you'll have everything in there to restore any of the cases that you find and come across daily. Okay. Yeah, and then that's it. So regarding the hands-on stuff, what we've done is we've actually printed out for you guys a little A4 printout with the drilling protocol based on the one side is X-line, the other side is C-line. We have on the tables bone blocks. So what I thought we could maybe do is do hands-on on the bone block first, where everyone just gets a chance to actually drill into the bone to feel what the drills feel like and feel what an implant places like in a bone block. And then after that, if any of you are still interested, we also have models available. So on the front part, I think there's 1 or 2 tables who don't have models where we're just going to have to share, but we've got what we call immediacy models. I'll show you guys. So they basically have, you'll see when you pull them out there, it's essentially a couple of exosites giving you a natural, sort of simulation of what you would be treating on a patient, where you can place an implant, we'll reverse it out, and then place it in another site again. Okay.
Step up and when we use the bone time. Just a quick so so you guys can follow it like
Have those been pre-drilled?
No, they've been pre-drilled.
Yeah, you're placing the implant already.
Steve said 800 for most of the CPs. So you've got the two bones, got soft down and
Which is stop.
part of the drill.
before placing your implant, you will just put that into the osteotomy and profile for the collar of the neck, basically around it, have a profile flare if there's any interference. I don't think you'll have that on your bone models. I don't think you'll have it on even on the actual arch models. But just if you feel there's any interference, you just want to see what they feel like, you're welcome to use them in the bone blocks and just see what they actually hold and profile the osteotomy as. So that's in a patient, for example, if you have a patient with really thin biotype, and the patient got like 1.5 or 2 mils of tissue thickness, and you're scared that that flaring collar might actually catch on the bone opposing medially or distally, you can use one of these to just profile around the collar. Okay. Any questions, just ask as you go. Whilst Nick is driving in an implant on the bone level implant, something I wanted to mention to you guys earlier about torque fit connection and that implant driver. So most implants normally will give an indication of what the insertion torque for the implant, the recommended insertion torque is. We spoke earlier about the differences in between the specialities. Now some people place their implants. A lot of the guys on full arch cases, especially with some of the newer like PETSI protocol and stuff like that, where they engage nasopalatine floor, or they place the implants a lot more palatally, where the bone is obviously a lot denser when you engage the palatal plate. A lot of times those implants are driven in at 80, 90, even 100 newton centimeters of torque. Not that that's the indication, but that's what some of the implant specialists do to ensure that the implants are stable and that arch can be loaded directly post-operatively. How with Stratton and how we ensure that they are able to do that is with the torque fit connection. That connection has been proven to be able to withstand under mechanical torquing over 200 newton centimeters of torque in the connection. So we don't recommend anyone ever placing an implant with that, but that is how strong that connection is. And what will happen with torque fit, your connection won't deform or fracture at 200 newton centimeters. The actual implant driver is designed to break at 160 newton centimeters. So we've kind of put a cap on it to say, guys, don't